Scalpel.
We've dabbled in medical dramas recently on this channel, but I've yet to review the sort of trailblazer of all medical dramas, Grey's Anatomy. You've been sending me tons of comments asking me to react to it, and I feel like it's some type of rite of passage for doctors on YouTube to react to Grey's Anatomy, right? But before we get into it, if you're new to my channel, welcome. My name is Dr. Jordan Wagner. I'm an ER doctor. If you enjoy the educational reaction videos and other stuff that you see here on this channel, please smash that subscribe button and turn your bell notifications on. That way you learn when I post a new video. All right, let's dive right in.
Look around you. Say hello to your competition. 8 of you will switch to an easier specialty. 5 of you will crack under the pressure. 2 of you will be asked to leave. This is your starting line.
Wow, what a good start. Thanks for joining us and working your butt off in med school, going through all your interviews, taking all your exams to try to be the top of your class and get into our residency program, and now we're gonna beat you down. That's kind of how it feels like, actually, sometimes.
Hi, I'm Isabel Stevens, but everyone calls me Izzy.
I have 5 rules, memorize them. Rule number 1, don't bother sucking up. I already hate you, that's not gonna change. Trauma protocol, phone list, pagers.
Pagers are the worst thing on the planet. We actually still use them in the hospital. Sometimes you can use your phone, text messaging now, but pagers, man, if you hear that go off, it's like,
Nurses will page you. You answer every page at a run. A run, that's rule number 2.
So that's the chief resident. I was a chief resident during my residency, in charge with another co-chief resident. So we actually end up just being liaison for the other doctors to the residents, as well as helping making the schedule and setting up like lectures.
On call rooms, attendings hog them, sleep when you can, where you can, which brings me to rule number 3. If I'm sleeping, don't wake me unless your patient is actually dying.
Surgical residents probably have one of the worst schedules when it comes to a resident because they are Q3 or Q2, so they're on call every other day. Like, this is crazy.
Rule number 4, the dying patient better not be dead when I get there. Not only will you have killed someone, you would have woke me for no good reason. We clear?
You definitely are even scared to call your attending. If you have a question, you're like, you really want to look it up before because you don't want to get yelled at or made to feel stupid. But when it comes to someone's life, you just call if you have questions.
Rule number 5, when I move, you move.
That's right. We always have like medical students or residents like either follow us even now as an attending. It's really funny. Everybody's like basically chasing the one person in charge and you always have to tell them like, wait, I'm going to the bathroom. You don't need to follow me.
Bryce, 15-year-old female, new onset seizures, intermittent for the past week.
We don't typically go to the helipad. Maybe a nurse or an EMT or a tech in the ER goes, but we're there waiting in the emergency department for, you know, everything set up, ready to go.
IV lost en route, started grand mal seizing as we descended.
Grand mal seizures are tonic-clonic, okay? They're very fixed movements, and as you can see, they're not trying to stop it. They are just letting it run its course. If somebody has continuous seizures over a certain period of time, that person is called with status epilepticus, which typically requires intubation if you can't get them to stop seizing. And if you actually have to intubate and sedate them, they actually need to be on an EEG monitor because you don't know if they're continuing to seize because you have them sedated.
Izzy, 10 milligrams diazepam IM.
10 milligrams diazepam, which is Valium. IM meaning intramuscular. So if they don't have an IV line, you can give it intramuscular. Sometimes you can give it intranasally, and they even have up the butt if you really have to for a kid.
No, the white lead is on the right. Righty, whitey, smoke over fire.
She's talking about smoke over fire. What the heck does that mean? They're trying to put the leads on the patient so they can monitor the cardiac activity. White is right. So white goes right shoulder, and then left is smoke over fire. So you put the black on the left shoulder and then the red on the left lower quadrant.
Dr. Bailey, let's shotgun her.
That means every test in the book, CT, CBC, Chem 7, tox screen. Christina, you're on labs. George, patient workups. Meredith, get Katie for a CT.
We don't necessarily use the word shotgun. You basically are doing like an altered mental status workup, which could be CT scans, EKG, chest x-ray. Like one of the first things you need to check is just a glucose level, which is just a finger prick to check to make sure that they're not hypoglycemic or crazy high hyperglycemia. And you're not checking everything under the sun because those are usually send out labs to a lab outside of your hospital and it won't come back in a day.
Open, identify, ligate, remove, irrigate.
Oh, he scrubbed in.
Identify, ligate, remove.
This
Faint
He's a feigner. No.
He's a feigner.
His pants.
Oh my gosh.
Bob Sweaty's gonna sweat himself on sterile.
$10 says he messes up the
He
McBurnie.
says he cries.
I'll put 20 on a total meltdown.
50 says he pulled.
Oh my gosh, I love it. Teaching hospitals have the viewing room so they can learn in different surgical situations without having to be in the room. Ooh, nice. He's using probably either 10 blade or a 15 blade to open up the skin. And then once you actually get through the skin, you don't just keep cutting. You actually use a bovie, which is basically a cutting electrical kind of knife that also cauterizes the blood vessels at the same time. There's always tricks to shaking hands. You just got to anchor them, because if you're free flowing, anybody's going to shake. But if you anchor it down on, say, like with a pinky, then you won't shake it.
Invert the stump into the cecum, but be careful not to
Rip it.
break.
Oop.
You ripped the cecum.
And now he ripped the cecum, which is basically the first part of the large intestine, which the large intestine happens to store our poop. And now you have poop leaking into the abdomen, and now you increase risk of infection. So you got to get in there, you got to wash it out.
BP's dropping.
He's choking.
Come on, George.
Sometimes people are like deer in headlights and they don't know what to do, but they also might be thinking to work in a fashion that is purposeful versus just reacting.
Today, pull your balls out of your back pocket. Let's go. What are you waiting for, suction?
Getting too low, folks.
So what do they mean? BP dropping, so blood pressure dropping. Blood pressure dropping is a sign of shock, which typically in this situation could be due to blood loss. Typically, it's gotta be a lot of blood loss to start that fast.
Doctor.
Go, 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 come on.
Wait. Pansy.
Oh, he froze.
Suction.
Oh no, that stinks. That's why you have the attending with you to help in those situations. And they're also teaching and guiding.
SPAP's not working.
That is not a grand mal tonic-clonic seizure. That is just abnormal movements.
Phenobarbital. Load her with phenobarbital.
There you go. Phenobarb.
You page shock.
Jumped a couple steps.
Told you. Well, page him again. Stat.
What do you want to do?
Yes. You gotta get the seizure to stop. Intubate.
Code blue. Code blue.
Well, now you're in cardiac arrest. They call code blue to get other resources down to that room, because the doctor's already there, right? But you need respiratory therapists, you need the ventilator, you need other tools, that sort of thing.
I'll get it. Right away.
Wait.
So she's putting gel on the
200.
charging.
Clear.
The gel and the pad, we now have like stick-on pads now versus these old school machines in the United States. So you do it basically right side of chest, left flank. Then you charge, and then you want to say clear, everybody clear, so like all clear, and then you shock. And then once you shock, this is an older show, so the current protocols is you continue CPR. You do not look to see if you shock them back into a rhythm.
300. 300. Anything? 27 seconds. Charge to 360.
300, that must be a monophasic, so get it up there. Just max it out. There's no harm to that. And so they're just stacking shocks is what this is called. It's not done anymore because it has been proven not to work well.
Anything? I see sinus rhythm.
Blood pressure's coming up.
Oh, it's a miracle. She's got her back.
Rate's coming back.
What the hell happened?
You wouldn't do it over a gown either. It needs to be on the tissue.
We're supposed to be monitoring her.
I checked on her and she.
I got her. Just go.
We're saying you're supposed to be monitoring. Yeah, it was. And then she had a seizure and she had a heart stop. Like, what am I supposed to do? And then you act in that situation.
I've got this kid, Katie Bryce. Right now, she's a mystery. She doesn't respond to her meds. Her labs are clean, scans are pure, but she's having seizures, grand mal seizures with no visible cause. I can't do it alone. I need your extra minds, extra eyes. I need you to play detective. I need you to find out why Katie is having seizures.
They're kind of rounding. So sometimes you can round on a patient where you're going around to each room. So that's what they're doing. They're discussing the case, and basically more brains are better than one.
Okay, she has no headaches, no neck pain, her CT is clean. There's no medical proof of an aneurysm.
Right.
But what if she has an aneurysm anyway?
Look, I appreciate you trying to
She
help.
fell.
It's not helping.
When she twisted her ankle, she fell.
It was no big deal, not even a bump on the head. You know, she got right back up, iced her ankle, and everything was fine. It was a fall so minor, her doctor didn't even think to mention it when I was taking her history, but she did fall.
Well, you know what the chances that a minor fall could burst an aneurysm? 1 in a million, literally.
But if you're looking for a burst aneurysm, you should have lateralizing signs. What does that mean? You burst an aneurysm in your brain on one side of the brain or the other, so it should affect basically the opposite side. That's why it's like kind of weird, but it could be in a certain area of the brain that doesn't actually show up on, say, like a physical exam, and you're having these seizures. Oh, They're doing a vascular study, an aneurysm study.
Here it is.
It's minute, but it's there.
They found an aneurysm.
It's a subarachnoid hemorrhage.
They could have just done an LP too, but they're not showing that here. So if you have a ruptured aneurysm, you'd have like a leakage of the blood around in your angiography that you're doing. Cool, good job, intern.
All right, everybody. It's a beautiful night to save lives. Let's have some fun.
But he just said there, like, it's a beautiful day to save lives. Like, every day I go into work and it's like, we're gonna help people, we're gonna save people's lives today. That's what we're there for, and that's why we went into this. I like statements like that because we are there to help. If you guys like this video, check out this one over here. And as always, like and subscribe. And thank you so much for watching. Stay healthy, my friends.